So I want to welcome everyone to our Valparaiso University class on religion, spirituality, and global health. I'm Professor Susan Holman, and our audience today includes the students in the regular class, as well as a small group of other VU students or faculty. I think we're all students. We've opened this session up to others at VU because we have a guest speaker today, who is Dr. David Addiss. Dr. Addiss, I'm going to introduce him now and then turn it over to him for the rest of our session. He's the director and founder of the focus area on compassion and ethics at the Task Force for Global Health, which is an international collaborative based at Emory University. He's a medical doctor who also holds a master's in public health from Johns Hopkins, and his career has focused on public health, on neglected tropical diseases, such as filariasis, which is worms, and leprosy, and since 9/11 on broader questions of global health as they relate to compassion and ethics. Beginning in the 1980s, Dr. Addiss spent 20 years working at the Center for Disease Control and Prevention, the CDC, and he co-founded and co-directed the World Health Organization's Collaborative Center for Control and Elimination of Lymphatic Filariasis in the Americas, based at the CDC. He was advisor to the World Health Organization. He worked with the World Bank and the United Nations Development Program, UNDP, and directed research and training programs in tropical diseases. And then came 9/11. And following the crises of 9/11, which you saw a little bit about in the readings, he left the CDC, first moving to the Fetzer Institute in Michigan. And there he directed their science and spirituality program. He partnered with WHO on violence prevention. He taught on social justice leadership and underwent a Upaya Buddhist chaplaincy program. These experiences, he says in his chaplaincy thesis, provided a powerful and creative lens through which to understand and address the spiritual hunger that I had experienced myself and witnessed in my global health colleagues, unquote. These experiences led to his current role with the task force and his work on compassion and ethics in global health. And I've really spelled it all out because I know that many of these pieces are of great interest to the students in the class. And his career journey is, I think, an extraordinary example of the healing synergies that can happen when global health, religion, and spirituality connect. And so we are just absolutely delighted to welcome him here today.
Thank you very much, Professor Holman, and welcome to all the students. I'll try to share my screen now, and we can go ahead and get started. Can you see the screen? Good, very good. I don't know if I'm able to actually see the chat while I'm with my screens share. So if you want to raise a question and I don't see you in the chat, please just unmute yourself and jump in, and I might ask some questions as we go through. So please don't assume that I can see the chat. I'd like our time together today to be a conversation. I have some slides to show, but we don't need to get through them all. And I really welcome your input, comments, critiques, and challenges. I'd like to frame this as just sharing some field notes from my experience and the experience of colleagues in global health, and invite us all into a conversation. And I really appreciate the chance to be here today. There's very few courses that I'm aware of that actually combine religion, spirituality, and global health. So it's a real privilege. I'm not seeming like I'm able to scroll down. So let me stop sharing there and open up another window. I think this is probably the one I want. Good. Okay. So we'll cover several things today. What is compassion? The challenges to compassion in global health, some critiques of compassion. I believe that compassion is actually emerging as a field in global health and as an energy, and I'd like to share the evidence for that. Talk a little bit about the epidemiology of compassion. Say a few words about opportunities for cultivating it, and then end on some thoughts about compassion or global health as a spiritual practice. When I was with my mother towards the end of her life, and she was receiving treatment for her cancer at this hospital on the right, we were waiting to be admitted to the hospital, and on the wall of the hospital admission room, there was this poster that really broadcast compassion and announced that the people in the hospital, the doctors and nurses and staff, reached out to people in need and gave comfort as Jesus did. It was kind of hard to process that sitting in a busy admission room waiting for the bureaucracy to churn, but I was impressed by this aspiration. That was a pretty high bar that they were setting for themselves. And I became curious about compassion in medicine. Started looking at websites of other hospitals. Here's the Massachusetts General Hospital. If you go there, you have a safe, compassionate environment. Emory University, you're going to the pediatric ophthalmology department, you get comprehensive and compassionate care. At a hospital closer to where you are, at Northwest, you're there committed to quality and compassionate care. Quite a large percentage of hospital websites announce and sort of broadcast that you get compassionate care there, which I find very interesting. In global health, you have to listen very hard to hear the word compassion. It's not a word that we use in our collective conversations. We talk a lot more about social justice, about equity, and about these population level values, but not about these more interior values like compassion. And yet, we often think of compassion and justice as sort of opposites. Compassion is very soft and justice is about action. But the Jesuit Roger Haight said that to be compassionate for all requires that we be concerned for justice. So since justice is the means through which compassion is realized at a population level, his co-author, Paul Knitter, basically looks at it the other way and says, unless the tree of justice grows in the soil of compassion, its roots will not go deep enough to bear lasting fruit. So compassion being required soil from which justice emerges. So I believe there's a much more positive relationship between these two. Yes, they may be in tension, but in fact, I think they're synergistic, properly understood. We can debate that point if you'd like. As I think I might have said in one of the readings that you were assigned, I became really curious about when I went to the Fetzer Institute and was conducting research on compassion and neuroscience. I became really curious about the role of compassion in global health, because it's not a word that we use very often. And I would ask my colleagues at CDC and my colleagues in Haiti who are working with patients with elephantiasis or lymphatic filariasis, what is it that motivates and sustains you in this work? Can you say this in one word? And when they were willing to play that game or be that vulnerable, it wasn't justice that they were saying. It was words like care and compassion and love. And they would say these words in a very vulnerable place. And it was a sort of a tender moment. And we realized that we don't share those interior values. I began to wonder what power might be released in the field of global health if we could actually admit to each other that it was care, compassion, and love that was motivating all of this work. with that, we convened some global health leaders. And actually, we built it around the schedule of Dr. Bill Foege, whose book you're going to be reading for your next reading, A House on Fire. Because at CDC, he was known as a compassionate figure. And we had several global health leaders participate, and they too had never talked about the role of compassion in their work, but they started telling their stories. And by the end of the meeting, they concluded that global health is rooted in the value of compassion, and it's grounded in an awareness of our interconnectedness. So we seem to be onto something here. It wasn't just my colleagues at CDC or in Haiti, but it was our global health leaders who also shared this common value. I'd like to talk a little bit about what compassion is, or at least how it's been understood and articulated. Karen Armstrong, who's a scholar of world religions, claims that after studying all the major world religions, she concluded that it's compassion that lies at the heart of all religious, ethical, and spiritual traditions. Karen Armstrong really says this is essential for us as human beings. It's the one thing that unites us as human beings across these different traditions. Ethicists have claimed over the centuries that compassion is the basis of all morality. Now, not all ethicists will claim this, and we'll see some counter voices to this, but Schopenhauer is an example of those who say compassion, the ability to put yourself in the other person's shoes and to care, that's the basis of ethics. In the last 20 years or so, there's been a whole field of compassion science rooted in neuroscience and psychology, and scientists have mapped the neural pathways that are active when we experience empathy, which are actually different than when we experience compassion. And they've shown how we can actually modify these neural pathways and activate new ones through practices such as contemplation, compassion training. So there's a very robust field of compassion science. There's a whole Oxford handbook of compassion science published a few years ago. And it's not something soft that cannot be studied. It's actually a very robust scientific discipline now. Modern psychology uses a certain definition of compassion that is pretty well accepted in the field. Dacher Keltner from UC Berkeley is one of the leading psychologists on compassion. And he says that compassion is a feeling that arises in witnessing another's suffering and that motivates a subsequent desire to help. So from Keltner's perspective, there's these components of feeling, there's a witnessing of suffering, and then there's an action, there's a motivation to actually help. I'd like to review now a model that's sort of a composite from social psychology that pieces together the components of compassion. And one of the things that science is telling us is that compassion isn't just one thing. It's actually made up of elements that come together so that compassion emerges. You can lump them or split them, but I tend to lump them together into three major elements. One is awareness, the other is empathy, and the final one is action. First, in order to have a compassionate response to suffering, we actually have to recognize suffering as suffering. We have to take perspective. We have to have a certain stability of mind and an awareness of the other person as suffering. There's a lot of things that can interfere with that cognitive awareness. And I'll present these as a linear flow. It's not necessarily linear, it's more of a spiral, I think. But I'll present them for simplicity as a linear pathway. When we recognize suffering in the other, we are emotionally aroused. The empathy is stimulated. We are actually able to feel the pain of the other person. We might not feel that pain if we think that person is undeserving or they caused their suffering on themselves and therefore are undeserving of our compassion. But assuming we are open to an empathic response, we have an emotional regulation component that is really crucial. If we're placed in the presence of extreme suffering, so if I'm asked to get out from behind my computer screen and fly to provide medical assistance at a refugee camp, where I'm not really alleviating much suffering, but I'm witnessing a whole lot of it, I might go into my personal distress and I get upregulated in my emotions of distress. And that stimulates sort of a fight, flight, or freeze response where I really want to avoid the suffering. It becomes about me and my suffering rather than the people who I'm there to help. I might get really busy and I might stay in the situation and just get really busy, but I'm acting to alleviate my own distress rather than to alleviate the distress and the suffering of the person I'm there to help. So this issue of emotional regulation is key. In global health, we might not have enough contact with individual people, the faces of individual people, to generate an empathic arousal that leads to compassion. On the other hand, if I'm thrown into the midst of too much suffering and I don't have the skills to emotionally regulate, I take on the suffering as my own, and I'm not going to really lead to a mature, compassionate response. But if I can regulate that emotion, stay present to suffering, but not be overwhelmed by it, then I can go into a place of compassion and desire to transform the suffering, and combined with the wisdom of how to do that. This is where your training in public health, in medicine, in nursing, in alleviating physical suffering is so important. The compassion and the knowledge allow us to have an effective action that actually alleviates the other person's suffering. There's a final component to this model that I think is really important for us, particularly in global health and in clinical care, and that's to not be over-identified with or too attached to the outcome. We tend to identify ourselves as healers, as maybe even saviors in some situations, and our attachment to the outcome actually gets in the way of the compassionate response. We become more concerned about having a successful program, about having the outcome, the clinical outcome that we want for the person in front of us, than we do about being present and doing what is ours to alleviate suffering, and then letting go of the outcome. That might seem paradoxical to some, and look forward to talking further about this. But before I go on, are there any questions or comments or critiques now? Yes, I see a raised hand. So Molly Fulton, please go ahead. The raised hand works, so please feel free.
This is a question that I've actually asked myself a lot, but it fits really well into the conversation right now. Do you believe that is there such a thing as a completely selfless act, like taking action to alleviate one's own distress and having to kind of draw that distinction? I'm just curious as to what your thoughts are on that.
Yeah, thanks so much for that question, Molly. The thing about compassion is it actually stimulates the pleasure centers of the brain. So, there's all this debate about altruism, where there's true altruism and true selfless behavior, but we're actually wired to be compassionate and to alleviate suffering. Even if we witness one person alleviating the suffering of someone else, that stimulates pleasure, the pleasure centers. So I don't think that it's about us giving compassion to somebody who receives it and being a selfless act. I think in the experience of compassion at some level, the giver and the receiver kind of meld. And compassion is something that's experienced between people or in the midst of people, rather than being something that flows from above to below or from giver to receiver. So I think it's probably not too helpful to fixate on whether our actions are selfless or not. I come from my background of a very sort of a strict Baptist background, and the whole idea of selflessness can take on some, I guess, unhelpful characteristics. And so a healthy self, being compassionate to ourselves, is also important in extending compassion to others. So it's a great question, and I find it not helpful to dwell on whether I'm being selfless or selfish, but rather focus on the experience of compassion and the dynamic that's really between people in that experience of compassion. Is that helpful, or am I avoiding your question? Yeah.
No, that was great. Thank you.
Okay, yeah. Any other thoughts? Monique, yes.
Hi, so my question is, for physicians doing emotionally taxing work with high death rates, such as trauma surgeries, how feasible is compassion? And how does compassion affect their mental status over time as they process the deaths of patients they were unable to save? Secondly, is there such a thing as too much compassion, especially in the field of medicine?
Yeah, what a great question. And I think they're related. There is this term that you may be aware of called compassion fatigue, which suggests that too much compassion is bad for us. And we're taught in medicine we need to be really careful about our emotions, because we become emotional and then we don't perform as well. And we also, how do we keep going if we really recognize the unintended consequences of our action? The neuroscience is teaching us that empathy, you can have too much empathy. And this is where and by too much, it's in that center box of unregulated emotion, where you sense the suffering and you don't know what to do with it. You're not doing anything to alleviate it. You're stuck in that emotion. Compassion actually moves from that to often it's the question, what one thing can I do? What is mine to do at this moment to alleviate that suffering? We may not be able to fix the suffering, and that's where not being over-identified with the outcome is so important. Matthew Ricard, who is a Tibetan Buddhist monk, he's actually a French scientist who has become the French translator for the Dalai Lama, and he's known as the happiest man alive. Matthew Ricard, I recommend some of his readings and certainly his recordings. He was put in a scanner, an fMRI scanner by Richie Davidson, who was one of the pioneer neuroscientists of compassion. This was in Madison, Wisconsin. And they were studying the brains of these Tibetan Buddhist monks who spent 30,000, 40,000 hours in meditation. So they have a pretty good sense of what's going on in their mind. And they would ask Matthew Ricard, Matthew, give us empathy at, generate empathy at 50% capacity. Don't burn out, but just give us 50%. And then they'd see where the brain networks lit up. After about half an hour of this, where they go up and down, he started banging on the side of the scanner and said, I can't stand it anymore. I have to go to compassion. And they said, okay, go to compassion. Different networks lit up. and he was completely at peace. What's different? It's that intent to act. And there's so empathy stimulates the pain sensors, but compassion truly understood, it generates a sense of connectivity, and it stimulates the pleasure centers because we actually feel good when we alleviate the suffering of others. And so I don't think, based on the neuroscience evidence, that we can have too much compassion. We can be stuck in empathy. And I think it's also for the surgeon who, and for really all of us in life and in medicine, we are not perfect, and people suffer because of our interventions unintentionally. Self-compassion and recognizing our own suffering is also an important part of that healing process. So I understand the rationale that we need to not be consumed by emotion, and we need to be steady in executing the surgery. I would say that surgery then is the action of compassion. And the empathy stimulates that compassion. But I would say that the surgeon does need emotional regulation in order to not be overwhelmed by the suffering, but they cannot have too much compassion. There are people who would disagree with me on that, but that's my reading of the evidence. Does that help, Monique?
Yeah, that's fascinating. Thank you. I do have a follow-up question now, though.
Sure.
I actually am starting medical school in July here, so this is very relevant for me. But how do you think that a medical student or a incoming physician is to learn emotional regulation? Is that something that is taught in medical training, or is this something you acquire through kind of your colleagues that are teaching you that have more experience? How is that learned?
Yeah, unfortunately, there was none of this when I was in medical school. At Emory University now, first-year students are encouraged very strongly to take compassion training, which largely focuses on this emotional regulation. It's called cognitively based compassion training. I'll point out a few examples of other compassion training towards the end of the talk, but there are opportunities now where there weren't 10, 20 years ago. You may or may not learn it from your attendings or the residents, but I imagine that almost in every medical school now, there's going to be somebody or some group of people who are keyed into this. And I think the COVID-19 pandemic has actually heightened the burnout, the emotional, the empathic overload. And so people increasingly in medicine are realizing that they need this type of training and skills. Yeah. And I would say if you can't find it among your medical colleagues, find the chaplains, because that's what they deal with. They stand in the presence of suffering, and the action that they offer is their own presence. And that is a very effective action. But they don't have IVs or surgeries or medicines. They actually, it's their person that is the action component there. And they have a lot to teach us.
Thank you.
You're welcome. Okay, thanks for those questions. That was great. Now there's some challenges to compassion in global health. And I'd like to just share a few of those. And I mentioned these in some of the readings, so it might be a repeat for some of you. In global health, we deal with populations, not just individuals. And we work at great distances, economic, cultural, geographic distances from people whose health we're committed to improving. You know, Jesus somehow had compassion on the multitudes. We're not wired that way. We have compassion on individuals. So, you know, how did that work? You know, the gospel writers don't really tell us how to do that. They just said he had compassion on the multitudes. We need to cultivate that somehow. And I would just say that in that sense, we don't have that empathic response because we're dealing with numbers. We're dealing with statistics rather than individuals. So we don't have enough empathy to generate compassion. Things become very mechanical. Bill Foege, whose book you're going to be reading, is a real hero for many of us in global health. And he returned to CDC after he had left as director and gave a talk. And he's talking to the world's, at the time, premier global health agency, public health agency. They deal with population health. And he said if CDC is to maintain its reputation, it's because in everything we do, behind everything we say, and as the basis for every program decision we make, we'll be willing to see faces, not laboratories, not smarter epidemiologists or new buildings, but be willing to see the faces of suffering. Another challenge is we work in these complex bureaucracies and partnerships. And people very idealistic get out of public health school, go into work at USAID or CDC, and might as well be working at an industry. It's just it's just the mechanics of the bureaucracy that kind of snuffs out compassion and this the active sort of restoration of compassion and the sort of the regeneration of compassion is just not there. It's not even part of the discourse. And then we also, in global health, we have a lot of different masters. Bob Dylan, you got to serve somebody. Well, we serve a lot of different people in global health. Military funds a lot of global health. There's political interests, and this creates a sense of divided loyalty. And this was very acute for my colleagues who were at CDC over the last year as the COVID outbreak ran wild, and they really were muzzled in many ways and unable to act on what their training and their compassion led them to want to do. And so dealing with these competing values can be a real challenge and leads not only to divided loyalty, but to moral distress. Now, there's also some critiques about compassion in global health. And to set that up, I think it's important to consider a spectrum of responses to suffering. On the one hand, there's mature compassion, the kind of compassion that we were talking about just a few minutes ago, with the knowledge and the wisdom of how to apply compassion, the ability to stay in the presence of suffering. On the opposite end of that would be cruelty, inflicting pain, inflicting suffering. And so cruelty would be the far enemy of compassion. There's also some near enemies of compassion, things that masquerade as compassion, and we might even call them compassion, but they're not really compassion. They come from a different place. And we call those near enemies. Mature compassion really comes from a sense of shared humanity, of solidarity, of really profound humility and being in this human body with other human bodies. Pity comes from more of a sense of condescension, of I'm sure glad I'm not like you, or I'm here to help you, I'm the great doctor, I'm the great public health person, and we're going to fix your situation. It's not from a deep sense of humility and openness, but more acting out our own agenda, our own need to be a helper or a savior. So let's look at a few critiques of compassion. One is it's an expression of superiority. And I think the most, maybe one of the strongest articulations of this position is Didier Fassin, a physician and philosopher in France, who basically says that compassion always presupposes a relation of inequality. When compassion is exercised in the public space, it's always directed from above to below, from the more powerful to the more vulnerable. Now, I think we need to take his critique seriously, but I don't think he's talking about mature compassion as we understand it from neuroscience and from the spiritual traditions. He's talking about pity. And it's very easy for us with our big programs or our fancy technology to assume a position of superiority and to slip into pity rather than mature compassion. Another critique is that it's really all about us. And this gets to, Molly, your question about, is it really about us feeling good or can we really be selfless? A lot of times our programs really are about us. This critique has been leveled at certain mission trips, short-term mission trips. There are some very good short-term mission trips, but they're not all good. And some of you might have seen this Instagram series, Barbie Savior, where Barbie and Ken are running around Africa, sort of saving the world. And this was actually developed by two missionaries who were actually trying to find an outlet for their experience of this superiority and this all about usness of the mission work that they were involved in, but started to critique. A final critique is that compassion is really an unstable emotion. And this would be the opposite perspective from Schopenhauer. This position says ethical decisions and maybe clinical decisions should be based on reason. So Socrates, Kant, Nietzsche would be proponents of this view. And they would say that emotions are really a poor basis for public policy because it privileges the faces that we can see and completely ignores the needs that we can't see. And thereby it promotes inequality and injustice. Now, when Bill Foege years ago was speaking to the Christian Medical Association in Kenya, he basically said, you guys have to see the numbers. You have to see the patients that aren't reaching your hospital and get away from this just serving the people who are coming to you. We need the public part of public health to make policy. But he's saying we need both. This critique would be saying that too often when we think of compassion, we're thinking about the emotional component, the empathy component, and without the wisdom that drives us to make decisions that are actually unjust and promote inequity. Avi Bang, a friend of mine who's a really pioneering public health physician in India, would argue that, yes, these critiques have their validity, but we really don't want global health without compassion. That global health decisions without compassion become bureaucratic and impersonal and insensitive and autocratic. So the answer is not, let's weed compassion out of global health. Let's just be staunch reasonists and base all of our decisions on numbers and reason. There's an implication of ethics. And I think my analysis of this is that we're out of balance here. In global health, we focus on numbers. We talk about justice and human rights. We make policies and we have these strong ethical principles. And those are all essential for population medicine and population care. But what we miss, in part because the need is so great, we're so focused on results, we miss the faces. We overlook compassion. We overlook the relationships and the frank dialogue among friends. And we, rather than the principalism of ethics, these abstract principles, we neglect the ethics of care and caregiving for one another. So I see this as there's a need for balance. We need both to be able to see the faces and the numbers. Now, Bill Foege again, you'll see that I'm a fan of his and I'm really excited that you'll be reading his book. Now, he was a Lutheran missionary in Africa before he became involved in CDC and a medical missionary. And he has something of, he's a wonderful man, but he's often some kind of inscrutable. So here he says, successful public health leadership in the next millennium will require the ability to see the whole and the parts, the faces and the numbers simultaneously. Public health leaders need to scan and focus and see relationships, and they need to do it all at the same time. So I said, Dr. Fahey, can you tell us how to do that? He's not responded. You might learn this in a monastic setting, this non-dual awareness, this ability to see the population behind the individual patients that you might see as a doctor or nurse. And for us in public health, we also need to be able to see the faces in the numbers and to do it at the same time. This is a spiritual practice, I believe. Okay. Is compassion emerging in global health? I believe it is, and I'll provide you some evidence as to why I think it is. There's a recent book by Stephen Treziak and Anthony Mazzarelli called Compassionomics, where they review all of the literature on how caring and compassion has been beneficial. What's the evidence? And they claim, based on their review, that compassion is good for patients, it's good for the healthcare provider, and it's good, even economically good, for the healthcare system. Now, the data are not as strong as we would like, but they're certainly compelling, and I commend this book to you, particularly if you're thinking about health-related field. At the World Health Organization, Dr. Tedros has put compassion at the center of healthcare quality. There's a big push now for universal health coverage, but what about the quality of that coverage? It's not just about the policies and what that coverage is, but how good is it? And he basically says quality takes a whole lot of things, but among them, compassion. So WHO has situated compassion as essential for healthcare quality. And that provides a great opportunity for us who are interested in this. WHO has really taken a leading role in looking at compassion as an element of quality. There's some webinars, and I'm very happy to share these slides and links with everyone so you can access them. A wonderful webinar on compassion is the heart of quality, people-centered health services. So that raises compassion as something that's as important as, say, clean water, as competent surgeons. It's essential for healthcare quality. There are countries like Ethiopia that have embedded compassion and caring and respect as a pillar in their health sector transformation plan. And this is in a sense radical because we've not seen it. We've grown away from that compassionate foundation for health. But here you have Ethiopia bringing it back into one of the 3 or 4 major pillars of their health sector transformation plan. Now that raises some key questions. How are they going to do this? How are they going to measure it? You have a program, it's one of your goals, one of your principles. How do you realize that? That brings us to the epidemiology of compassion. Let me ask a question. And when people say epidemiology of compassion, what are you talking about? Because when you experience compassion, either as a giver or receiver, do you experience it at the same level of intensity or quality at every moment, in every place, and with every person? Does anybody want to weigh in? Or do you experience it differently? Is it clustered in some way? Is it uniform, homogeneous, or is it, you experience it heterogeneous in different levels of intensity, in different times and places? Anybody want to weigh in? Monique?
I always feel like I feel more compassion when I'm thinking about myself in reference to someone who I feel like I connect to more, I can relate to them in their situation as it compares to my own experiences.
Mm-hmm. Yeah, absolutely. That whole thing of connection is really important. So if I were to put you on the spot and say, so it's clustered then, it's not constant in time and space for you. It tends to cluster in some ways related to connection. So connection might be a factor that predisposes you to that experience. Is that right?
Yeah, I'd say so. I know I tend to have like a soft spot for some of my patients as a CNA that I relate to more. I have one patient who's from a small farm town like me, and she's always talking about her life on the farm and milking the cows. And I just have a lot of compassion towards her, I think, as compared to other ones that I don't necessarily connect with,
Yeah.
just because we share a background interest.
Excellent, excellent. Well, I agree with you. And I think thanks for sharing that experience, because you're really focusing on this element of connection and our ability to connect with people, in a sense, as a risk factor for the emergence of compassion. When I ask most people, and my own experience is that compassion is not constant. It's not like air. It's something we experience in different levels of time. Sometimes we're open to it, sometimes we're not. Epidemiologically speaking, it's clustered. Well, all epidemiology is the study of why things cluster in time or by person or in place. We have theologies of compassion. We have psychologies and neuroscience of compassion. What allows compassion to cluster? What allows it to emerge? If we're going to study programs, if we're going to actually measure compassion, we have to understand the risk factors for compassion or how it emerges. And in infectious disease epidemiology, there's this thing called the epidemiologic triangle. When you're trying to figure out the cause of an outbreak, you ask questions about who is it affecting? Who's the host? What is the environment like? And what is the agent that's being transmitted? Compassion can be considered as a host factor. We can learn to be compassionate. It's a skill that I have. There's a compassionate environment. There's some energetic field set up when you're with one of your patients, Monique, that you have a compassion, it evokes compassion for you. And then there's, compassion can be considered as an agent, something that's transmissible from one person to another. So this is something I just wanted to share with you. We're exploring this idea of compassion now as the epidemiology of compassion. It might be just a harebrained idea, or it might have something to contribute to scaling compassion up in the world. And I think it has several potential uses. We held a meeting here last year at the Task Force for Global Health on the epidemiology of compassion and love, just trying to get our handle on that. I'd be happy to share the report of that meeting. But there are several different ways in which I think the epidemiology can contribute to scaling up compassion or allowing it to emerge, including just describing what's going on, identifying the factors that allow it to emerge or risk factors, validating the measures, testing interventions, and then monitoring progress towards the goals like the Ethiopian Federal Ministry of Health have. Happy to answer questions about this in our conversation. I'd like to talk a little bit about the opportunities to cultivate compassion, and we raised this a little bit earlier. There's so many opportunities to cultivate compassion, and our relationships are really one of the crucibles in which we learn about compassion and the need to have compassion both for others and ourselves. As Karen Armstrong said, almost all major world religions, spiritual practices or spiritual traditions have practices and teachings about compassion and how to generate that, how to progress as a compassionate individual. And then there are compassion training courses that are now available. The two on either side are loosely based on a Tibetan Buddhist practice of compassion training, which goes back centuries, but it's been stripped of the Buddhist, in a sense, theology and offered as practices that anyone of any faith or no faith can practice. One is offered by the Compassion Institute, another by the group at Emory, the cognitively based compassion training. And these are just two, and they're very widespread, and you can read about them online. There's also compassion training that's rooted in the Christian tradition. some friends of mine at the Claremont School of Theology, Frank Rogers and Andy Dreitzer, have developed compassion practices and essentially training based on the Ignatian spirituality of Catholicism, a little bit of Jungian psychology thrown in, but it's really available and accessible to people of all Christian traditions. And it's very excellent training, and you can read more about them as well. So it's not limited to a certain religious perspective or theological belief. There's also training available for organizations to become more compassionate. And we've done some work with the Center for Compassionate Leadership for training global health professionals. On the right, you can see the curriculum there. You see there's some things about the work of the self, building the self, mindfulness, self-compassion, building a culture of compassion, belonging, being aware of our blind spots where we exclude or stigmatize certain people. A lot of the compassion training has to do with self-awareness and being willing to look really carefully and honestly at our own stuff, and at our own biases and our own projections. In the cohorts of the classes that we've offered with the Center for Compassionate Leadership, we've asked people what their personal challenges are to being a compassionate leader. And you can see that the two leading causes are trouble saying no, getting too busy, and perfectionism. Lack of self-compassion is another one. So these are things that we all experience, but they actually are barriers to compassionate leadership and to experiencing compassion. There's all these external challenges, which are very similar: the excessive demands on our time and overwork, and legacy of colonialism and systemic issues, systemic racism and other biases that limit compassion. So I wanted to share these are some real world examples of some of these barriers to compassion. I'd like to close with just a few thoughts on global health as a spiritual practice. Professor Holman mentioned that after 9/11, I left CDC a few years later, and really CDC had changed radically during those right after 9/11, and we really started focusing on civil defense rather than public health, and we need civil defense for our nation, but we also need a broader perspective that we're all in this together rather than an us versus them perspective. And public health, global health are based on that more inclusive worldview. I went to a Zen center for a retreat, and I saw this Enzo, this Japanese sort of circle of wholeness, painted by Thich Nhat Hanh, the Vietnamese Buddhist monk. And it just stopped me in my tracks, because it was talking about, for wholeness, we need peace not only in the world, which I'd been working for 20 years at CDC, but we also need peace in ourselves. And this is where I had gotten burned out. I was so focused on health in the world, achieving these public health goals, rising through the ranks, that I had neglected myself and neglected the health of myself. And this is something that's, I think, endemic in the health professions, certainly in global health. And the message here is that wholeness requires both. We can't achieve peace in ourselves unless we're working for peace in the world. And we can't achieve peace in the world unless we have peace in ourselves. So here again, these are not intention. They might be perceived as intention, but we need both for wholeness. And in that sense, these pulling together of these tensions of faces and numbers, peace in oneself versus peace in the world, this is a spiritual practice. Thomas Merton talked about this. He wasn't talking about global health, but he might as well have been. He said to allow yourself to be carried away by all these conflicting concerns, to surrender to too many demands, to commit to too many projects, to want to help everyone and everything, is to submit to the violence of our times. We are so earnest in accomplishing all these things, in alleviating suffering, and yet he's saying if we become imbalanced, we're succumbing to violence. There's another way, which we don't pay that much attention to these days. And Saint Seraphim of Seraph, a Russian Orthodox saint, just said, you don't need to go to college and get a degree. You don't need to train to become a physician or go to global health. Just acquire a peaceful spirit, and around you thousands will be saved. Well, we discount that. We also discount Joan Halifax's Zen saying, if you take care of your mind, you take care of the world. So there's this component of global health as a spiritual practice. We need to take care of our own minds while we're taking care of the world. And it's not one or the other. In practical terms, I've asked people, my friends, how do you see the faces? How do you maintain compassion in your global health work? And I'll just share a few thoughts that they have. One is by traveling, by really engaging with people in different cultures. This is a slide. I was younger in those days. I'm in Eastern Nigeria, meeting with my colleague in the red shirt, Oladele Akogan. And this woman is sight impaired. She also had elephantiasis of the leg. And Oladele was introducing me to her. And you can see she's kind of looking at my hand and saying, what's with this guy? And Oladele was laughing. And I said, what's going on? She said, this guy's hand is so soft. Doesn't he do any work? And so that experience, I just love this picture. And just being out in the field exposes you to these experiences that remind you of our common humanity. Taking photos and remembering those connections. That sense of connection is so important. I think you mentioned that, Monique. And photos help us remember. These personal relationships that transcend space and time can be very important, particularly with people from other cultures. Religious and spiritual practices, we've mentioned, compassion training, and also sharing our stories. When we've given physicians and scientists the opportunity to talk about compassion and talk about why they enter this field in scientific meetings, they really enter it, and they have to kick us out of the room because everybody wants to share their story. So sharing our stories is a really important source of sustenance for us. You can all boil it down to Father Gutierrez, Gustavo Gutierrez's comment. He's widely regarded as a founder or father of liberation theology. He says, concern for effective action is a way of expressing love for the other. Global health, we have a strong concern for effective action. It really is an outcome of our love for the other, and we need to hold both of these in our work as we try to improve the health of others. And with that, I know I've gone on longer than I had initially wanted to, but I've really enjoyed the conversation, and I'm very looking forward to your questions and comments. And I'll stop sharing right now.
So Dr. Addiss, thank you so much. And there have been a number of questions that have, you might want to open the chat now and take a look.
Great. Good.
Some students have shared questions with me directly, so they may, of the questions they've shared, and also the question of mental health actually keeps coming up. So I wonder if you could talk a little bit more about mental health. The Joan Halifax quote was very helpful, because I often think mental health is important, but how do we incorporate it into population health as a concept? And you've touched on that, but if you wanted to say more about that.
Yeah, that's a huge issue. And I think it is really absolutely critical. And I think mental health is one way of looking at at this emotional regulation and mental health, I think are really tightly tied together. And, you know, we have these cognitive distortions that affect our mental health. We have these emotional just surges that also affect our ability to perceive reality. And so, in a sense, mental health there's mental health provides a lens, and I think we're really talking about something very similar here. Spiritual health and mental health, I think, are not always, they're not synonymous, but they are related. And our capacity to be with and engage with reality in a non-defensive way and in a compassionate way is so much more, we're so much more able to do that if we're mentally healthy. I think there's a movement in global health for, I think as you've studied this, sort of the community-based mental health, which is really gets at some of these basic coping and emotional regulation skills. So I think it's very much associated with what I'm talking about as well. Yeah, and I think we collaborate a lot with people in the mental health field around this issue, and there's a lot of common ground there, I would say. Yeah.
Thank you. I see some raised hands.
Yes, Joe, and then Noel.
Yeah, hi. Okay, well, thank you very much for the talk. I very much enjoyed it. But so with the mental health kind of aspect, you know, and Monique pointed out, you know, burnout, and you talked about it as well in the CDC. So as you know, burnout and mental health issues can be prominent amongst physicians. You know, how can we really, you know, expect them to help us heal and to help, you know, heal the world when they themselves are struggling? You know, like, I don't know if it's comments on the whole med school and busy lives kind of thing, or, you know, just what are some of your thoughts about that?
You're absolutely right. And I think many physicians with COVID-19 have been pushed over the edge. I think one of the challenges for us in the caregiving or helping professions is admitting that we are human and that we suffer as well. And I think it's this continual push to this attachment of our identity as the problem solver or the savior or the caregiver or the helper. It feels like it's a luxury for us to recognize our own suffering and to attend to that. That's not helpful. And we need each other in this journey, and we need to recognize our limits. And so sometimes it takes bottoming out and recognizing that you really can't continue with that kind of attachment to your identity and this constant push to, in a sense, save the world. I call it a compulsion to save the world. It comes from a good place, but it also gets, I think, because of the messages we receive in medical training and nursing training, we are unable to recognize our own suffering and attend to it and recognize that we also are human and need help. So you're absolutely right. I agree that unless physicians are aware of their own limitations and see themselves as both in need of compassion, but also as able to give compassion, and also being able to let go of the role, let go of the identity, and be a human being. There's so much nurture that comes from that level of humility where we're all human, and that fosters a sense of connection and true compassion. So I think we are in a crisis now with healthcare because of the stresses and because of the incentives, both professional and personal, to carry that kind of guardedness and that sort of self-protection that ultimately is not functional when stressed. So I fully agree with you, Joe. Yeah. Let's see, Noel, yes, please.
Thank you, Dr. Addiss.
Yeah.
I was thinking that the apparent uselessness of the result of treatment seems like it's less important than compassionate interactions, and
Mhm.
that maybe we should realize that things like quiet rest and chatting with patients, which might seem useless, actually are useful. I was wondering if, in general, there are any daily spiritual practices which can help people to reconcile themselves to feeling useless and realizing that they're really useful even when they're resting.
What a great question. Yeah, I think part of the challenge is giving up our idea of uselessness and usefulness. Um, that's that letting go of outcome. And I think, part of it is responding to the moment and uh, engaging with what is in the present. If you think about a lot of things that give us pleasure, sports or art, are essentially useless from a utilitarian perspective. So this is where I think we have a lot to learn from chaplains and hospice care and palliative care, where it really is about that moment of connection. It's really about being useless in community with someone or in connection with them. I think we have such a utilitarian and mechanical view of what is useful that we often neglect things that are actually much more meaningful. Yeah. I had surgery recently, and I can tell you that it was successful, and I'm glad I had surgery, but the only person in the hospital that really attended to me as a human being was the phlebotomist who would come in at 2 a.m. and draw my blood. She was only there for 90 seconds, maybe a couple minutes. We didn't say much, but I felt that she was there spending those 2 minutes with me. Yes, she was getting my blood, but we were having a conversation. Something about her presence was healing, and that was not the case for any of the other healthcare providers. She didn't have to be useless in that time with me. She could have just come in and said, stick your arm out and I'm going to take your blood. There are practices now helping physicians and others pause, take a breath, and close the container on the last patient you saw and be settled and grounded as you enter the space with the new patient. Joan Halifax at the Upaya Zen Center has a grace practice, GRACE, and each of those letters stand for something, which essentially is that pause, that momentary pause, centering oneself in the present and then being open to the next encounter. And really, I think a lot of what we learn from compassion training and meditation is that ability to pause, to be centered, and then to be open to what comes next. So I think we have some tools that are available to us now to be in that useless space and be present that we didn't have before. Thanks for your question.
Thank you.
Yeah, you're welcome.
There's a question.
So many questions in the chat. Which one should we take on? Yeah.
I would say I will invite Sky to, if she wants to speak on questions she wrote out.
Okay.
I just noticed that like as I read things, I tend to almost replace words as I read it. So reading through the perusal readings, I kept hearing empathy as I was reading compassion. I don't know if that makes any sense, but I was wondering if you see empathy and compassion as synonymous in this context, if you think that one is more draining, especially during a pandemic, or if one is more beneficial to lead with without going through the sort of like mental strain that you were discussing.
Yeah, I think if I can, let me just, I think I have an auxiliary slide that might illustrate that. Stop share. Now, if I can't get it right away here, I will give up. Let's see if I can go way down to the bottom here. Okay. Yeah, this is what I wanted to show. The neuroscience, oh, wait a minute, did that? Neuroscience, can you see that? Neuroscience would say that based on the neural imaging, empathy can lead to, empathy is perceiving, being able to read the emotion and experience the emotion of another. And it might be empathic joy, where somebody's celebrating, you can celebrate with them. That's empathy. It's ability to put yourself in the other person's shoes. And this shows that there's two sort of outcomes of empathy, particularly empathy in response to suffering. It can turn inward and where you're overloaded, and where you are basically leads to burnout and negative feelings. On the other hand, if it's coupled with that intent to act and that the pleasure that comes from alleviating suffering, then it's much more of an other related emotion, and compassion can emerge. So some people talk about empathy or compassion as empathy plus action. Now, do you need to be flooded by emotion in order to be compassionate? No, you might be predisposed to respond to compassion, or to suffering with compassion. You don't need a huge emotional response to lead to compassion, but you have to be able to sense where the other person is and desire to alleviate that suffering through either your presence or a specific action. So one way, a shorthand way of looking at this is that compassion is empathy plus action, or an action sort of loosely defined. It may be a desire to act. You may not be able to actually solve the situation, but it's a desire to act. And one thing that I try to do when I'm feeling in the sort of emotional distress, not knowing how to respond to suffering, is I ask, is there one thing I can do in this moment? And it might be saying hello to someone. It might be something very small, but having that one thing moves me from this empathic overload to a sense of action, even if the action is not going to fix something, but it might help alleviate the suffering. So I see empathy is what motivates you into compassion. If you're skillful and you can emotionally regulate, and it's essential because unless you are actually aware of the suffering, you have a resonance that other person's suffering, you're not going to want to do much to alleviate it. I hope that helps. Yeah.
We're about at time, so I wanted to thank you so much for your time with us.
You're very welcome. I'm really pleased, and I would love to, if there are questions, I'll see if I can copy the chat, and I'd be very happy to try to respond to these, or please feel free to reach out, and I'll share my slides as well with you. So I really appreciate the time with you today, and sorry that I've gone on a little longer than I wanted to, but I would love to stay in touch with you, and I'm so pleased that that this course exists. We need a class like this in every university, I think, and so my appreciation to you, Professor Holman, and to all the students.